I'm Sydney Spradley, and I did a corrective exercise intervention on the functional movement screen for the inline lunge test. FMS refers to the concept that seemingly unrelated impairments in a remote anatomical region may contribute to or be associated with the patient's primary complaint. This is geared toward people who are not currently injured to assess their dysfunctions and correct those dysfunctions to enhance performance. This is not an injury diagnostic tool. It mobility, stability, and neuromuscular deficits may be exposed. The inline lunge attempts to place the body in a position that will focus on the stresses simulated during rotation, deceleration, and lateral type movements. This places the lower extremity in a scissor position, challenging the body's trunk and extremities to resist rotation and maintain proper alignment. The inline lunge is used to assess the mobility of the hip and ankle, stability of the hip, ankle, and knee, and flexibility of the quadriceps. For our patient, we have a soccer player, and the FMS inline lunge test resulted in a fail bilaterally. This test reflected muscle imbalance, inversion in the feet and ankles, and a forward lean. Problems to improve on are mobility, flexibility, stability, motor control, and pain. The ultimate goal of this functional progression is a succession of activities that simulate actual motor and sport skills, enabling the athlete to acquire or reacquire the skills needed to perform safely and effectively. Short term goals would be mobility and stability, because those are the two most important factors that affect everything else. Long term goals would be a greater movement efficiency, meaning movement that occurs without pain or discomfort and involves proper joint alignment, muscle coordination, and posture. This leads to improved performance and decreased risk of injury. To achieve these goals, we will go through this corrective exercise series of inhibit, lengthen, activate, and integrate with a progression of exercises. Exercises will increase in intensity and resistance, thus progressing the exercises. First, we will begin with foam rolling. Because this is a soccer player with lower extremity dysfunctions, we will begin by foam rolling the lower extremity. Foam rolling aims to seek and destroy. The patient should scan the muscle or tissue to be released by rolling it from the origin to insertion all the way through the entire length of the muscle to find the most painful trigger points. Next, go back to those trigger points and hang out on that spot until the pain or spasm decreases by 50%. Then find another trigger point and repeat. You can do this on the glutes, the IT band, quadriceps, hip flexors, and hamstrings. Mobility is the first brick in the wall, meaning it is the foundation of functional movement. When mobility is limited in one segment, it causes systematic compromise to some degree, at some level, in some region. Compensation, substitution, asymmetry, reduced efficiency, poor alignment, and faulty posture can all be traced back to a mobility problem. For exercises, we will go through ankle mobility of standing, half kneeling dorsiflexion, and band. Hip mobility will go through stride with hip external rotation, hip internal rotation stretch, stride with spinal rotation, and for quadriceps, we will do a prone quad stretch with rope. For the progression to the next exercise should only occur once the patient achieves that exercise correctly and without pain. The first exercise is ankle mobility standing. The patient will keep the heel of the back of the foot in contact with the ground at all times during this stretch. They are to lean forward and bend both knees, driving your back knee over your toes. Do this for 5 to 7 reps. The second is half kneeling. The feet are wider than the midline. The dowel is placed vertically next to the pinky toe. While keeping your knee down, shift your knee forward to the outside of the dowel to maintain your weight of the ball of your foot, fifth metacarpal, and heel. Do this for 5 to 7 reps. Ankle mobility with band. Anchor the band to a chair leg and place the band around the lower tibia with a decent tension, keeping both legs straight. Keeping the heel down, bend one of the involved legs to increase ankle dorsiflexion. The band helps to glide the tibia anteriorly on the talus. Do this for 5 to 8 reps. Hip mobility, stride with hip external rotation. The involved hip is flexed and externally rotated, placed on a table about mid-thigh or higher. The knee remains in line with the hip, and you can see this in the second picture or the picture on the right. Flex the stance knee enough to feel a stretch in the flexed hip. Do this for 5 reps and a 10-second hold each time. Hip mobility with hip internal rotation. Internally rotate one hip and place the opposite foot on top of the internally rotated leg. Slowly let gravity pull the hip into a greater stretch. Do this for 5 reps and a 10-second hold each time. Hip mobility, stride with spinal rotation. With the foot placed on the table, stand with the involved hip and knee flexed. Maximal stride positions should be assumed. The opposite leg should be extended at the hip and knee. Torso and spine should be in neutral and erect posture. Lean toward the table, maintaining an erect spine, slightly bending the knee, and rotate the spine toward the flexed hip. Do this for 5 reps and a 10-second hold each time. Hip mobility, prone quadriceps stretch with rope. Lying prone with involved side on the table and knee extended. The opposite foot is placed on the floor with the hip flexed in order to attain a neutral spine. Actively flex your knee by pulling the rope above your head until it is a slight stretch in the quadriceps is felt. Extend your knee against a slight resistance. Range of motion should increase with each repetition. Do this for 5 to 7 reps and a 10-second hold each time. Now, moving on to stability and motor control. Stability is the ability to control force or movement. It is a precursor to strength. Stability training can only begin once an improvement in mobility has occurred. That's why we had to work on mobility first. Stability reinforces new mobility, and the new mobility provides new sensory information, which is required for new and improved stability. For this, we would go through exercises of a leg lock bridge, a half kneeling chop lift, half kneeling dowel twist, lunge position with shoulder circles, and hip activation progression. This is the same for the last exercises. That progression to the next exercise should only occur once the patient achieves that exercise correctly and without pain. The first exercise, leg lock bridge. Begin by lying supine with one leg flexed at the hip. Hold one thigh to the chest for a passive lock. Thigh should remain in contact with the chest throughout the movement. Extend the hip into a bridge position. Do this for 3 sets and 10 reps each. Next, half kneeling isometric chop lift. With arms extended isometrically, press the dowel into the wall, activating your abdominals and glutes to stabilize the position. Switch position of the legs and repeat. Rotate the body isometrically, press in the other direction. Switch position of the legs and repeat. Do this for 5 reps and a 10-second hold for all positions. Next is a half kneeling dowel twist. Keep the spine as tall as possible. Feet should be close to the midline of the body. Hold a dowel or stick across the shoulders and twist in the direction of the front leg. Twist as far as possible without losing posture or original leg position. Twist toward the down leg. Hips will want to rotate, but don't let them. Stay tall. Do this for 10 reps and a 30-second hold each time. Next is a lunge position with shoulder circles. Start in a lunge position with both feet facing forward, chest over the forward knee. Keep hands placed on a box or chair. The opposite arm of the forward knee initiates the movement. Raise arm into full flexion above the head. and rotating the thoracic spine at the same time. Make a full circle about the shoulder. When the arm gets to the side of the hip, reverse direction and return to the start position. While the arm is circling, maintain your balance. Don't let your back foot turn out. Do this for 10 reps. Next, we have a hip activation progression. Start with arms extended overhead, feet together. Bend forward, placing the hands onto the edge of a 4 to 6-inch platform, keeping the knees as straight as possible and press into the platform. Move into a stride position by extending the right leg, keeping the spine extended, looking forward, and bending deeply through the left knee and ankle. Left heel should remain in contact with the floor. Pressing into the platform, lift the arm, rotate the spine, and turn the head. Hold the hand toward the ceiling with arm fully extended and palm up. Do not rotate through your hips. Maintain a stable position and on the flexed knee. Return to the stride position. Flex the left knee as much as possible right while maintaining maximal hip extension on the right knee. Maintain a tall spine. Return to the stride position. Return the right foot to the platform and switch legs and repeat the sequence. Do this for 3 sets and 10 reps each. Here's an outline of all the exercises with the reps of ankle mobility, hip mobility, stability, and motor control. Just a reminder, progression to the next exercise should only occur once the patient achieves that exercise correctly and without pain. If they are not able to do it without pain, the exercise may be modified to a simpler movement with less strain. As for return to play, because this is not a rehabilitation program due to injury, there is not a return to play protocol. After this corrective exercise progression, the athlete should move more efficiently and without pain. Thank you.